Okay, today's presenter is Dr. Virginia Powell. She is our pediatric intensivist from Carilion Children's Hospital. Dr. Powell did her, and she's going to correct me, she's standing by to correct me if I'm messing this up. She did her medical school at the University of Maryland, and her fellowship started in Buffalo and then finished her last few years in Rady
Children's Hospital.
Rady Children's Hospital in San Diego. Dr. Powell is our section chief for pediatric ICU and the medical director for the pediatric ICU, and has been with us at Carilion Children's for the last 9 years, going on 10 years. And today she is going to talk to us about childhood drowning. So I am going to turn it over to her. Thank you all very much for joining us, and thank you, Dr. Powell, for taking the time to do this presentation.
Thank you, Alex. Okay, we'll get started. First off, just to cover our bases, I have no conflicts of interest to report. Introduction. Drownings is an important public health issue. We will talk about various aspects of drowning during this talk, but I feel like it's important for the pediatric and family practice groups in particular to hear about these, as well as ER physicians, because most drownings will not make it to the PICU, unfortunately, but will die or be treated in an emergency room. Key thing that I like to also bring up is that drownings occur quickly and silently. I've tried at various times to embed some of the public safety messages that get put on through typically Safe Kids as TV commercials about drowning. The thing they're difficult to embed in a talk, but you can easily go on to YouTube and just start Googling for drowning commercials, and they are interesting to watch, but the key thing they really try to emphasize is that it is a silent event, that unlike our TV shows, unlike what you see when there's a drowning on any sort of media show, whether it's TV or movies, they usually show someone struggling and flailing and screaming. And the reality is that when you're at the point of realizing you're going to drown, you've used up all your energy, and so people just sort of quietly slip under the water. There's some interesting ones that may even be beneficial to show your patients where they have closed circuit cameras on swimming pools and lifeguards watching the pools, and there'll be a person that actually has a near drowning event, and you can find it on the video, but when you see it without the arrows pointing to it, you would never have found it. So it's very educational to see that, and some of those things, if you have patients with swimming pools that are doubting how quickly and silently a death can occur, you might want to show them some of those or suggest they look at them. Definitions for this study: drowning refers to the process resulting in a primary respiratory impairment from submersion or immersion in a liquid medium. So drowning can be anything from going under in the bathtub, being submerged in a bucket of scrub water, to the sort of classic drowning we think of someone flailing around in the ocean like you'd see on TV. And you should use the term drowning if you're seeing a patient in billing or in coding, regardless of the outcome. The term drowning is what we should be using, rather than using the terms near drowning, secondary drowning. We used to try to differentiate whether patients, did you call it a near drowning if the death occurred over 24 hours after the event or not? Was it a secondary drowning at that point? What did you call it? And the recommendations in terms of how we code things and track the events from a public health standpoint is that we should just be calling it a drowning when they come into your facility and are being cared for. There was also differentiations between wet and dry drowning, and I guess this is as good as any place to bring up that topic. I haven't seen it this summer on the Facebook postings, but the dry drowning that made the circuit a year or two ago on Facebook is a completely bogus event. What is meant in the medical literature when they talk about wet drowning versus dry drowning, and I have a slides a little bit later that talk about it as well, is whether or not water got into the lungs versus whether the drowning occurred because of the hypoxia with breath holding, but no actual breaths occurred that brought water into the lungs. It does not refer to the child that sputtered in the pool one day and then has some sort of medical event a few days later. There was a tale on Facebook a few years ago, and we found a lot of parents getting alarmed by it and bringing kids into the emergency room last summer, where the kids had just a simple sputtering, probably did get a little bit of water in their airway, but they were completely conscious and aware and functioning fine. And the parents were alarmed that this was going to cause their child to die the next day or two. And that is a complete non-recognized medical event, I guess is the best way to word it. But I've not noticed people complaining of that this year or asking me questions or seeing posts on Facebook, but every once in a while you might have a parent ask about something like that. In terms of epidemiology, it was pretty amazing to me when I first started looking at drowning years ago in training to realize that it is one of the leading causes of death worldwide, and in the United States sort of fluctuates between the second and third leading cause of accidental death in children. Motor vehicle accidents, homicide, suicide typically are the leading ones, but within accidental deaths, the drowning is in that top group, varies a little bit from age to age, whether it's number 2 in one age group and number 3 in the next age group. The thing to keep in mind is it is a pretty significant cause of death in children and something we should be addressing in anticipatory guidance and finding out from families whether or not they have swimming pools, what their family behaviors are in terms of things like going to the lake, use of life preservers, swimming lessons, etc. And for every drowning death, they're estimated to be anywhere from 1 to 4 non-fatal drowning events that require hospital attention. And that varies, and not very good data is kept on the non-fatal drownings, so we don't have an accurate number for that. There's a variety of epidemiologic studies that are trying to look at that count, and they'll look at ER visits and coding for those ER visits in communities near the ocean or in communities where there's lots of swimming pools versus very few, et cetera, but we don't have a real accurate count on that. In terms of age and gender distribution, and I did see something in the newspaper recently that the public health system was concerned about the fact that there's more males than females, but that's true of a lot of accidental injuries. We see an increase in males over females, more typically in the adolescent years, and that's what the graph is showing, the 2 different colors, the sort of teal color females and the purpley blue, I believe that's periwinkle, is males. You can see both at the younger age and older age that the males have a higher rate than females, and that's thought to be related to males typically having more risk-taking behaviors than females. And then in the age distribution, the less than 1-year-olds is typically kids that either had the drowning in a bathtub type of situation due to not having paid attention to. Then they get into the walking toddler age in that 1 to 4. Some of those are bathtubs. Some of those are a child going headfirst into buckets. Others may be related to swimming pool events. The age group that you get into the younger years, or as you're getting more into school age groups, drops down. It's thought to be in those groups you're going to have more kids with swimming skills, and then in adolescence you'll see it peak up again a little bit, and that's thought to be related to more risk-taking behaviors, being out on the water, perhaps boats, and activities with alcohol and drugs may or may not be involved, but that is part of the tick you see going up in the teen years. let's see, this is covering part of that. Let's see, the peak incident, we talked about the 1 to 4-year-old group, and those are brief lapses in adult supervision, bathtubs, buckets, swimming pools, and keeping in mind, and this is good for your anticipatory guidance, is that it only takes 2 inches of water for a child to drown. And then in the adolescents, peaking in the 15 to 18-year-old group. And those drownings are more likely to be associated with, as I said, the risk-taking behaviors and to be in natural bodies of water. So other risk factors to think about, and we don't always think of this right off the bat, but it should be part of our anticipatory guidance, is seizure disorders. Kids that have seizure disorders, we should think about this both with swimming as well as even taking tub baths. It should be part of your anticipatory guidance with a family that it's recommended that if they're taking tub baths that they be closely supervised. I had the misfortune of taking care of a teenage girl who apparently loved to soak in a nice hot bathtub, and because of her pretty poorly controlled seizure disorder, she was on quite a number of seizure medications and still had frequent breakthrough seizures. Her family did not feel like she should take tub baths, and it had been recommended that she not. Being a teenage girl, she really didn't want someone sitting in the bathroom with her. But she was discovered in the bathtub with a drowning episode that she ended up being neurologically devastated from. And what the family had figured out was that she would run the shower while sitting in the bathtub and keep the shower water running at a low enough speed that it didn't overflow her bathtub, but that the family didn't realize she was actually had the tub plugged and was able to soak in the tub. So I'd never thought of that as something to give a parent anticipatory guidance on in terms of a teenager doing something like that, but it is something to think about, and it is part of my discharge instructions with a new seizure diagnosis, is that they need to have their bathing monitored and showers recommended to bathe independently. Cardiac arrhythmias, the classic story is a swimmer who has a prolonged QT syndrome, that this has been unrecognized, and during a swimming or diving event, that with the physical activity triggering the episode of the prolonged QT syndrome, having a lapse in consciousness and drowning. And again, I've had the misfortune of taking care of a child where this occurred. He was actually an identical twin, and his twin was diagnosed as well with the prolonged QT syndrome after that event, but unfortunately was devastating for that child. In terms of pathogenesis with what happens in a drowning, the primary injury is a hypoxic ischemic injury. Once you get beyond the actual drowning event, our care in the PICU is very much focused on what any hypoxic ischemic injury would entail. But at the time of the actual drowning, and this is where that dry and wet drowning sort of mentality and previous efforts to tease out which is which comes into play, is that a person will go underwater and they may have some aspiration of water into the hypopharynx area. Some of that can trigger a laryngospasm, and that's estimated to be about 10 to 15% of people, and that would be in reality what a dry drowning is, not whatever Facebook says it is. But that because of the laryngospasm, they don't actually get water into their lungs, but they still have a hypoxic event because they are not breathing and underwater. The wet drownings would be where the water has been able to get past the vocal cords and into the lungs and has injury because of volume of water in the actual lung parenchyma. The event, whether it's dry or wet drowning that occurs, would be the cerebral hypoxia from lack of oxygen, development of acidosis due to not being able to get rid of your CO2, and subsequent cardiac arrest. And then the actual amount of brain injury would be related to the length of the cardiac arrest and abilities to resuscitate the patient when the event is recognized. Other things to consider that would add to your treatment of these patients and could contribute to worsening of the hypoxic ischemic injury and other things as a medical provider taking care of them would be whether there was an associated trauma. For example, was this a drowning incident and the patient actually struck their head while they were diving, I'm sorry, I think I said drowning, a diving incident where they might have struck their head and caused a neck injury, or could there be drugs and alcohol ingestion involved in the event as a reason why they went under the water and didn't protect themselves or their airway, didn't bring themselves up, had they become unconscious from a drug or alcohol ingestion. And then as I talked about on a few slides back, the underlying seizure or cardiac disorders that could have contributed to the event. Once the patient has had that hypoxic ischemic injury, the sequelae of what's going on with hypoxia, hypercarbia, acidosis, you're going to have decreased myocardial contractility. There'll be elevated pulmonary and systemic vascular resistance, and all of that will lead to cardiac arrhythmias and eventually cardiac arrest. So not unlike any other reason that there may be a hypoxic ischemic injury if a patient were in a suffocating situation due to being wrapped up in the blankets in their bed, or whether they're underwater. Either one will eventually lead into a cardiac arrest. However, for reasons we don't fully understand, CPR in response to the arrest has been shown to have better outcomes from other causes. It's not really clear why, but when they look epidemiologically at large case studies of pediatric cardiac arrests and outcomes, the subgroup of patients that drowning is the etiology, you seem to have a slightly better survival to discharge. With one study had 32% versus 7% in non-drowning injuries have survival to discharge. Many of these, if you look at the statistics in terms of when they had return of spontaneous rhythm, it's at the scene with good bystander response, and CPR started immediately. In terms of post-resuscitative with myocardial dysfunction, post-resuscitation, the patients may remain in shock with ongoing need for pressors. If they survive to get into our pediatric intensive care unit at that point, particularly with older children that family report have good swimming skills. We want to investigate for underlying cardiac anomalies, abnormalities that may have caused the drowning, and would certainly contribute perhaps to some of the myocardial dysfunction post-drowning as well, a need for cardiac support. Neurologic injuries, which is obviously going to be the most debilitating thing that we're worried about in terms of outcome. The degree of neurologic injury is related to the duration of the cardiac arrest and the response to the initial resuscitative measures. So my word on this is that any CPR is better than no CPR. Bad CPR is better than no CPR. So would definitely feel like, and in terms of anticipatory guidance, that all families should have people trained on how to do basic BLS life support. Go to your local communities when these programs are underway. Lifeguards, certainly if it's a lifeguarded pool, the lifeguards are going to have CPR training, but if you have a home swimming pool, whether you have it or not, it's never wrong to get your CPR training. But just trying to do something rather than just like on the TV shows where everyone stands around and watches the person dying while you're waiting for the ambulance to get there. If you can jump in and do chest compressions and breathing immediately, you're going to have a better outcome, a better likelihood of return of spontaneous circulation, and the shorter the period of hypoxia, the better the neurologic outcome. Cold water drownings, they're reported to have much better outcomes, but much of that is anecdotal. Your Reader's Digest in the doctor's office always has a lovely long story about the patient that was underwater in some cold Colorado stream in the middle of the winter and was under for, I don't know, 8 hours and still survived. Some of that is quite anecdotal, but there is a benefit with the cooling. There are reports, legitimate reports of cold water drownings with prolonged resuscitations that have what seems to be miraculous outcomes. The medical literature claims that those true cases are with significant cold water there. Wintertime in bodies of water that are quite cold. They're not just a little chilly like here in Virginia, but places like Minnesota, New England, where it gets quite cold in the winter. It's unclear whether post-resuscitative cooling would be beneficial in these cases. With the research looking at therapeutic hypothermia, the cases that did well in the pediatric world with cooling were, just as with the adult literature, are more likely to be related to acute cardiac events and not something with a prolonged respiratory event. So it's unclear whether post-resuscitation therapeutic hypothermia, keeping that patient cold, is indicated, but certainly would be something on a case-by-case basis to think about. With the cold water drownings, in terms of resuscitation, and if you're not getting return to circulation that you can measure, you may need to do warming measures. In my fellowship training, I had one of my attendings was from Minnesota, and he said they actually kept an ECMO on standby in their emergency room for drowning resuscitations, hypothermia resuscitations, because when people came in, they were so cold that you couldn't resuscitate them until you had warmed them to some extent. But with other warming measures would be warmed IV fluids, gastric and bladder lavages, doing things to help with central warming. And then in that warming process, if the length of downtime, if the response to therapy leads you to believe that therapeutic hypothermia may be beneficial, then you would limit how warm you pursued getting that patient, whether you kept them for 24 hours at a cooler temperature with some mild hypothermia rather than a full rewarming to normal temperature. With lung injury, there's in looking at how much water needs to be in the lung to cause injury, as little as 1 to 3 mLs per kilo of aspiration into the lungs can cause some amount of lung injury. There may also be some aspirated vomitus. When you think about the patients that are patients that have had a drowning event, a lot of them, whether it's been recognized or not, have been struggling in the water for a period of time. They typically have swallowed quite a bit of water from the body of water they're in as part of their struggle, and so there's a high risk that they may have vomited, and some of that vomitus is part of what's been aspirated into the lungs. The results with whether it's just the water or if it's vomited material would be surfactant dysfunction and increased capillary endothelial permeability, which will cause issues with pulmonary edema. And you're going to, between the surfactant dysfunction and endothelial permeability, going to develop into atelectasis, poor lung compliance, and ventilation perfusion problems with ongoing hypoxia. So in these sicker patients, it's not surprising to see ARDS picture develop and quite a bit of ventilatory support needed and skills related to managing that ventilator support. Both fresh and salt water will disrupt surfactant, but by different mechanisms. There was a researcher back in the 60s that put a lot of energy into studying fresh versus salt water and how it might disrupt things, but at the end of the day, either one are going to be leading to worsening hypoxia and increasing work for your intensivist to manipulate the ventilator. So it's kind of less important to tease the two apart, but just to be aware that either one can cause some surfactant issues. Pneumonia actually is a rare outcome of drowning. Prophylactic antibiotics are not indicated. But in terms of the patient I have in my ICU with a bad drowning, I'm going to be watching our infiltrates developing. Is there fever? Is there a white count? And some of those patients may require antibiotics, but if you're in an ER situation or a patient that has a sputtering episode that's significant enough that they've come into your practice for attention, prophylactic antibiotics are not indicated. You may want to watch them over time to see if something develops. Do some anticipatory guidance with the family to come back if they develop a fever and ongoing respiratory symptoms. The ARDS certainly is something that's concerning in a patient that's had a severe aspiration event to the point of showing up in my ICU. But again, that's not going to typically be something you're going to see in your primary care practice, but more of the patient that's had a full drowning event with more invasive resuscitory efforts needed, but can be an ongoing sequelae that we're managing in the intensive care unit. Electrolyte evaluation, because of the amount of fluid that may have been swallowed by the patient in the drowning event, you do need to think about that there can be alterations in serum electrolyte. The estimate and research studies of how much needs to be taken in is 22 mLs per kilo to alter their electrolytes in terms of aspiration. So what we talked about on one of those earlier slides is that it's only 1 to 3 mLs per kilo that's typically aspirated into the lungs. So to get to that 22 mLs per kilo to alter your serum electrolytes is an unlikely event, but what is more likely is that taking in the over 11 mLs per kilo through the GI system in terms of ingesting fluids. The fluids brought in over that amount may alter the serum electrolytes. And so the flailing patient that has swallowed quite a bit of water and gets brought into your emergency room may have some changes in electrolytes. So the literature does recommend checking electrolytes if it's been a significant event, even if they're breathing spontaneously when you see them in the ER. Traumas, and certainly here at Carilion Roanoke Memorial Hospital, they're going to come in as a trauma alert or a trauma response. In younger children, you also have to think about things like non-accidental traumas leading up to the submersion injury. In adolescents, you're getting a urine drug screen and blood alcohol as part of the initial trauma evaluation, and then just looking at the patient closely as to whether or not there was some sort of mechanism of injury that may have occurred. So looking at, was this a diving event? Had they struck their head? Whether or not this might have been a foul play with non-accidental trauma where a child might have been held underwater, whether or not there was something caustic in the material that was inhaled into the lungs. We've all seen the buckets that have the little drawing on the side about a child going head first into the bucket. If you have something with some cleaning material in it or other caustic material, you do need to think about the effects of what was in the bucket. I, as a younger person looking at those pictures, thought it was kind of silly that everything had those on the side, but watched my own child at about 18 months of age trying to get something out of a bucket and turn upside down in it. Fortunately, there was not water in the bucket, but it really happens, and it has to do with the mechanisms of the child having the larger head so that the body weight is heavier at the top. They're trying to reach in. They sort of teeter on their waist on the edge of the bucket, and then their body weight carries them forward, and once they're upside down in the bucket, they can't easily get themselves righted even to like sort of spill the bucket over. So that's something that seems a little silly when you see the pictures on the buckets, but it's real. Prognosis is, outcomes are very closely related to the duration of the submersion, how long it took to resuscitation. Aggressive resuscitation up front gives you the best chance of survival. Unfortunately, it also will increase the survival of those that have a neurologic devastation, but you definitely, CPR early, CPR at the scene is going to be much better than waiting for your 911 response. It's hard to draw conclusions from how the patient looks in the immediate period after the return of circulation. I've taken care of several patients over the years that were not giving us a whole lot of evidence of neurologic function immediately after return of circulation. Their level of consciousness was not purposeful. Even pupil response is not particularly good, but within 24 hours, much more reliable outcomes can be predicted by the exam at that point. So typically, when patients come into our pediatric ICU, even with a pretty dismal neurologic exam, we're going to support them for 24 hours and depend more on our follow-up neuro exams at that point. Milder drowning events, as I said before, the statistics are not really kept for these. There are some studies where over the course of a particular summer, someone has kept track of it in various ERs or over the region of the country to try and guesstimate what the incident of milder drowning events are, and they're thought to be somewhere in the 1 to 4 range, 1 to 4 for every drowning if you look at the statistics for that area. And there are some that get hospitalized for hypoxia and others that are able to be discharged from the emergency room. In terms of criteria for ER discharge, and this is something that often comes up where we'll get a call for the ICU for someone that had an event that was of significance for drowning, where they might have had some hypoxia on arrival into the ER, but they've been weaned to room air, but someone still feels like they need an ICU. Some of those patients might be able to go home. Some you might want to watch on an inpatient setting, but if they're not requiring oxygen, there's really not an indication for transferring to an ICU. Children that did not require any resuscitation, they have a Glasgow Coma score of 13 or better on arrival to the ER, could be considered for discharge after a period of observation with about 6 hours being recommended to be discharged to home if no hypoxia has developed. Chest x-rays aren't a real good predictor of clinical course, so more on your physical exam, what their oxygen saturation is doing, what their work of breathing is doing. And unlike Facebook reports, the medical literature does not report late neurologic deteriorations in those patients. So if someone did not need CPR, they had a coughing, sputtering event that seemed somewhat significant, they might have needed assistance in getting out of whatever body of water they're in, but and they may be a bit dazed and confused, but they're breathing spontaneously, they have a heart rate, and they come into your emergency room. If that oxygen saturation and work of breathing and breath sounds look good at 6 hours, you could safely send them home. If you have any concerns that they do have some mild oxygen requirement or increased work of breathing, it certainly I would admit them for ongoing observation, and then any patient that is having significant increased work of breathing, any patient that needs intubation, obviously we would be wanting to refer them to a pediatric intensive care unit. Getting into prevention and anticipatory guidance, it's estimated that 80% of drownings are preventable, that things could have been done to provide barriers or monitoring that would have prevented that drowning event from happening. Adult supervision is key in the younger ages. I've, over the years, taken care of many, many small children that have had drowning events in their bathtubs where the parents say, I only left the room for a minute, and come back in and the child is unconscious in the bathtub. Some of those had very quick responses and still had heart rates so that they weren't a full cardiac arrest. Others, unfortunately, have either had dismal neurologic outcomes or death. So even your bathtub is something you need to be paying close attention to. In terms of swimming pools, I hope we're all finding out if our families where the kids are either live in a home with a pool or live near homes with pools, that there's appropriate barriers around the pools. Using personal flotation devices, meaning life jackets, realizing that things like the little arm swimmies that the kids like, they do seem to be a little bit more comfortable for the kids and they like it, but you need to keep in mind that in terms of safety, that those can slip off easily. So you would, while they may help your child stay above water in the pool, it's not something that you should depend on if you're out on a boat or if you're stepping into the house for a minute while they're swimming in the pool. If your child can't swim without them, you should not be leaving them unattended with that and think that they're protected from them sliding off and potentially drowning. There's no study that demonstrates that swim lessons will drown-proof a child. There was a bit of controversy a number of years ago where the American Academy of Pediatrics was actually recommending that you not do swim lessons. I believe it was until age 4, and that caused quite a bit of attention. And the intent there, my understanding was that they felt it was giving parents a false sense of security, that because their child had taken swimming lessons that they didn't need to be supervised as closely. I think the take-home at the end of the day was that it's fine to do the swimming lessons, but just keep in mind that in some ways, and I think part of the intent too, was that some of the kids that had been scared of water and would have been more respectful of that swimming pool because of their fear have gotten over the fear factor of going in and getting their face wet, but don't really have the good enough swimming skills to keep from drowning. However, on the flip side, a lot of the swimming schools love to advertise that they will be drown-proofing your child and teaching them when they go in the water to flip over onto their backs. I don't know that anyone has quite settled the controversy over that, but what I would tell parents, if they, whichever direction they choose for their own child, that they remember that nothing is going to replace good supervision when the child is in a body of water. In terms of Roanoke laws with swimming pools, the Roanoke County and City follow what they refer to as Consumer Product Safety Commission's handbook guidelines, which state that there should be a barrier fence around a pool at least 48 inches high with openings not over 4 inches wide, meaning that a size that a child couldn't slip their body through. If there is a door that opens from your house that goes directly into the pool area, there needs to be some sort of an alarm that will activate so that if you're in the home that you can know that someone is going into the pool area. These are interesting laws, and I'm not sure in Roanoke how well they're enforced. Prior to coming to this area, I was involved in a move in the community I was in before to try and get legislation where we would not only need a barrier fence around the yard, but a second fence around the actual pool. And that was fought very hard by the contracting legislative people because it increases the cost of the home, and that increased cost would deter people from wanting a pool in their backyard. So there was quite a bit of controversy over whether to have the requirement of a second barrier. But one of what I thought was a really heart-wrenching public service type of TV commercial I saw a number of years ago just shows running water in a sink and a person's hands doing some kitchen work in the sink, and a female voice that's of the sense that they're talking with a child, and then an alarm sense of, where are you? Where'd you go, little Johnny? And then realizing that the child is, they cut to the pool and the child is face down in the pool, and what they're trying to emphasize is how quickly a child can get a door open and slip out into a backyard and into a swimming pool in the backyard without the parent that's supervising them being aware of it. So those things just happen quickly and should be part of our anticipatory guidance. So we should be asking our patients about pool and water activity. We should encourage our families to have CPR training. Ask families that do have home pools what barriers they have. Do they have a fence with a gate? Do they have that gate latch high enough that a child can't easily open it? Are they cognizant of closing it after every time they use it? I've taken care of children that have been had very close neighbors that they slipped into the neighbor's yard and drowned in the neighbor's pool, unbeknownst to the neighbor who did not have children and wasn't really thinking about something like that happening. Knowing your local laws concerning pool barriers and checking with families whether they're following those laws. The other thing we learned is that there's not a whole lot of activity to enforce the laws, that while some of the communities have laws for things like second barriers, there's no one riding around neighborhoods making sure it's really happening. Discussing bathtub safety and encouraging that while swimming lessons in some studies have been shown to decrease drowning, at the same time there's no study that they truly drown-proof children, so they should never replace a need for supervision. Other information to share with families in support of these recommendations would be that 75% of swimming pool drownings are in children between 1 and 3 years of age. Many of these are actually being supervised by one or more parents, and then over half the victims have been seen inside the home a short time before the drowning event occurred. 65% of drownings occur in the family's own pool, and fewer than 2% were actually trespassing into a pool that wouldn't have expected a child to be there. And about 77% are reported as only missing 5 minutes. And whether that's really only been 5 minutes or it's just that our perception of time is somewhat skewed. One of the classic things I've seen over and over again is the family that's basically done everything right. They've been at a swimming pool, they've had a great day, they've had the picnic with a group of family friends, they're packing up to leave for the day, the kids have been taken in the house, put into their regular clothes, and the family's all busy packing the car to go home, and someone discovers the child that, you go to put the kids in the car and one of the children is missing and they're in the pool and have drowned. I've had that happen multiple times, and I think it's, even a parent that's trying to do everything right, that you put your guard down at that point, because in their mind everyone's done swimming for the day, but until you've actually left that pool area, you need to be keeping a close eye on the kids. One of the cases I had where that happened, I was working in the ICU, and a family came and had asked if I was there, and I didn't recognize the family or the name at the time, but the little boy came in with this is a picture of that he had drawn for me and had a box of cookies, and what happened was he was the youngest of several children, and they had been in that exact situation. They had been at a friend's house swimming for the day. Everyone had a great time. It was about 18 months to 2 years at the time, and while the family was packing up their car to leave, they didn't realize he had gone back to the swimming pool area. He was pulled out, required full CPR, arrived in our ICU, still intubated, but with a spontaneous heart rate. And in that initial exam, I thought we were going to have a devastated case. He had essentially no spontaneous movement, no response to pain, and pupils were minimally reactive. But fortunately for him and the family, he actually had a good recovery. 24 hours later, he was neurologically very appropriate. We were able to extubate him. He actually had minimal lung involvement and had a good outcome and went home. This is the case you want to have. And actually it turned out that his family, he was so young, they had never really told him what had happened, and it was sort of the family secret that the older children talked about. And so they had decided on the think he was about 8 years old at the time they came to see me. That was the anniversary of when it had happened, and they felt like they should tell him. So after they told him, I was very touched that he wanted to bring me cookies and visit the ICU. So that's my happy outcome from what could have been a really bad event for him. Thank you.
Okay, thank you, Dr. Powell. I am going to slide the phone over here to me. I've got several questions that we wanted to run through. We've got about 10 minutes left, so if you need to hop off the line, that's totally fine. I do want to answer a couple questions we've had come in from the group. The first one, I want to make sure I get this right. When you were talking about water aspiration and changing of electrolytes, is it the aspiration into the lungs that changes your electrolyte and blood volume, creates those abnormalities, or is it the ingestion into the stomach that causes that?
In reality, it becomes the ingestion into the stomach. The research that was done a number of years ago, and it looks as if there were a group of researchers putting quite a bit of energy into looking at what would change electrolytes and blood volume. We're talking about pretty significant volumes of water into the lungs in their rat model that they used, and in reality, when we look at patients that drown, they don't come close to those amounts. So it's what's getting into the stomach and what's absorbed is the issue, whether it's salt water, which would change your sodium, or hypotonic water, your classic pool water that is low in sodium that might dilute out your sodium amount, just like a plain water excessive ingestion without a drowning event might alter electrolytes slightly. But even then, it has to be a pretty significant amount. But in a patient that's had a true drowning to the point of cardiorespiratory arrest, there could be enough in the stomach to make alterations in their electrolytes.
Okay. Next question, and it's more of a kind of a generalized prompt. What would you say about kind of our diving reflex for our younger kids? When does that go away? What effect does that have in this situation? Would you just kind of touch on that a little bit?
The diving reflex refers to one of the reflexes children are born with, where when cold ice water is applied to the face, you get a protective response with a drop in heart rate and some apnea as a result. It's thought to protect a child if they are going into water. It's one of the things that gets thrown around in the literature as a theory for some of these kids with a better outcome is that you've gotten a slow bradycardic rate that is perceived by the responders as no heart rate, but in effect they've had a bradycardic rate going on the whole time. We're not quite sure how long that reflex will persist, but that outside of the neonatal period, it's not something that can be depended on, and so it really isn't discussed too much in the drowning literature at this point.
Okay, great. Last two questions, and then we will open it up to anyone on the phone line. The first one being, I mean, you're in the pediatric ICU, so you're getting calls from ERs outside in the community. Do you give them any recommendations? And you talked about antibiotics. You've talked about a couple of things. Do you give them anything specific if they start asking questions about, a kid who had an event, did require some resuscitation, but has now had that return of spontaneous circulation? Do they oftentimes want to start them on CPAP or BiPAP or intubate them right away for airway protection? Is there anything out there that you think we need to kind of myths we need to bust, or people are trying to do the right thing, but we're maybe thinking too much about it? We need to kind of let the clinical symptoms or H&P kind of direct us. What advice do you give to ER clinicians who are calling you about what to do while they're waiting to transport a kid to you?
That's a very individualized response. It's a little hard to give a general answer. The sort of three groups you're going to look at, one would be the group that could go home from the ER, and I think sometimes because of the emotional reaction of the parents that clinicians may be a little reluctant to send someone home from the ER, but certainly even if you do decide at that point that you would admit them just for an overnight observation, they don't need to be in an ICU, and that would be the group as we talked about. You're 6 hours out from the event. They never required CPR. They're awake and alert in your ER, and they don't have an oxygen requirement. They don't need an ICU. The ER literature would support discharging them to home, but there's certainly going to be some parents that are just so freaked out by it that you're having a little bit of difficulty doing that, and they could just stay in a outlying hospital that had pediatric care, or if they needed to come here for pediatric care, could go to our pediatric floor, but most of those in reality could go home. The kids that are having respiratory distress, I would have a lower threshold for accepting into the pediatric ICU as opposed to just putting them out on the peds floor if there was a true persistent oxygen requirement, because you do worry about there being surfactant washout and disruption and that evolving into worsening respiratory distress. And again, some of that may just require a period of observation to tease out floor versus ICU, but we would never refuse talking to a physician about it and getting a sense of where you are with that. And then obviously the patient that's needed intubation and the patient that's needed CPR is going to need to come to the ICU. Even with a good CPR response, you're going to want a period of close monitoring and looking for other respiratory sequelae as well as cardiac, and more of a workup in terms of was this a prolonged QTC or something of that sort.
Perfect. Thank you very much. The last comment I wanted to make, and then we will open it up the last few minutes here. You and I were talking before we started about kind of a trend that's happening now. It might be too soon to call it a trend, but something that is occurring with kids trying to hold their breath or compete with holding their breath, and there's some physiology that might be happening that could contribute to them drowning. Do you want to quickly touch on that?
Sure. When kids are playing the game of, who can hold their breath underwater the longest, what happens with hyperventilation, and I think most of us forget about this, is that your drive to breathe is really based on what your CO2 is doing if you're otherwise a healthy individual, and not what your oxygen level is as the stronger driver for breathing. So if someone is truly hyperventilating themselves well so that they can hold their breath longer, at least in theory, and unfortunately it probably does happen on occasion, is that you can hold your breath long enough that you can become hypoxic enough before you become hypercarbic enough to force you to want to breathe. So that, and if you're underwater when that happens, you could become unconscious and have a drowning episode related to that hyperventilation game. So if the kids are doing the hyperventilation game, you want to be paying close attention to that. If they go underwater and they're not coming up for a period of time, someone really needs to be paying close attention that this may not be a child that's still voluntarily staying underwater, but rather they become unconscious because of hypoxia setting in and causing that loss of consciousness before hypercarbia made them want to bring their head up and take a deep breath.
Okay, excellent. All right, so we've got about 3 minutes left. I'm going to go ahead and open the phone lines. So if you are on the line and you do not want to ask a question or make a comment, if you would just put your phone on mute now.
The conference is now in talk mode.
Okay, does anyone on the line have a question or want to make a comment in the last few minutes? I got several that I think we've already answered and hit that came in during the presentation. So. Okay. All right. We'll leave the phone lines open here for just a second. Just a reminder, if you are listening to us you can claim your Category 1 AMA PRA credit. If you click on the CME survey that is in your calendar appointment or in the YouTube video notes, you'll get taken to that. You can always find out how many CME credits you have by going to our CarelionClinic.org/CME, clicking on the CME tracker system. There's also a little pop-up window when you close out the CME survey that links to that, so you can get straight there after you submit your survey. You can always join us for a Grand Rounds or Lunch and Learn webcast. You can contact me. My information is down there at the bottom. With that, well, if there's no other questions or comments, I see some people taking off. With that, we're going to go ahead and disconnect the phone lines now, and thank you all very much for joining us.